approximation on the affected shoulder, okay, that's increasing the stability here, correct? We can always ask our patient, I'm here, my hand is there, to bend. So have your weight on this shoulder, okay? So the elbow is now bent, and then tap on the triceps, okay, followed by movement. Okay, so let's do it again. Body weight on this side, okay? This kind of applying some quick stretch on the triceps, right? Which followed by facilitation of muscle contraction here. You can tap on the triceps belly and then ask the patient to extend. If they can extend by themselves, it would be great. If they can't, you help them this extension. But you get the facilitation by the quick stretch you apply on the triceps during this movement. Okay? A quick stretch, followed by tap on the quad and the triceps, and then extension. Okay? This could be done in this position. My patient needs stabilization, so I'm gonna be in front of the patient now. My feet would not change position, so I am here. This will prevent them from sliding forward. I'm failing off the table too, right? Ask my patient to sit nice and tall, so I'm gonna be correcting him first, okay? So he's now in a good shape, good posture, right? I can start rhythmic stabilization, right? So then you hold, don't let me move you, okay? So here is one direction. The other direction. I can do shoulder against pelvis. So please hold, don't let me move you. Here. Okay. And I can do it this way. Hold, don't let me move you. Okay. And switch. Hold, don't let me move you. Okay. Here. Hold, don't let me move you. That's rhythmic stabilization. I can do dynamic reversals. I'm sorry, stabilization reversals first, okay? So push me forward, okay? Hold, 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 and relax. Okay, hold, don't let me move you. So I did it anterior, and I'm doing it posterior, okay? Do that side to side. So hold, let me move you. Hold, the other side. Sometimes we have patients with a dislocated or subluxated shoulder. This position is great for them, but is there any other alternative for this? Yes, I would have my patient arm here. So this is the less affected, okay? So carrying the affected side this way and have the patient, the thumb should be on the inner side of the arm, the fingers on the outer side. According to NDT, okay, here, this is distal key points of control. You have the thumb abducted and extended, means that you decrease spasticity all through the limb, okay? And my hand would be here, okay? I'm holding also this, and ask my patient to lean forward. This could be done this way, and please now move backward. I'm not pulling him, just move backward, okay? I can resist deflection, okay? So push forward, go, 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 go. Dynamic reversal, okay? And going backward, I can pull him from this side, but not this side, okay? So push forward, please. Again, here, go, okay? This is one of the controlled mobility things. This is a weight shift thing, okay? We can do that side to side. So please lean to your good side. Good. And then to the bad side. Okay? This can be done freely. And I also can resist. So lean to the good side. Okay. Now to the bad side. Okay? So I am sitting in front of the patient, holding the patient here, okay? This arm is kind of supported. No worries about the subluxation that may happen on the shoulder. The patient is carrying it, and also you are helping him doing this. Okay? In this position, in sitting, relax. Thank you. In this position, I will be going back to the patient side here. Okay, we can start doing some reaching activities to cone. Okay, in front of the patient. Okay, so the patient left the arm and reach the them. Okay, so when they reach the them, they use the trunk to lean forward and get him back. Okay, this is what we do in our real life to reach for stuff. Okay, if the patient, of course, able to do this with the affected side, that would be great too, right? And a patient with pusher syndrome. This guy is always pushing away from the less affected side. Okay, so towards the affected side. Here's the affected side, and he's pushing towards me. I want him to cross, to go to the midline. Where should I put the cones? Here or there? So they can reach there. Okay, so they would reach to the other side, to them. Okay, and grab them to the midline. Okay, with the less affected side. Okay, so now they can reach two things, so they cross the midline and get it back to the midline. And lean other way again, this way and here. Okay, you can also do them here, a little bit this side, okay, because they are already there. Reach and go. Reach and go. The magic thing about the pusher syndrome, if you have a mirror in front of them, okay, and this mirror should have a line in the middle. And this one has it. Okay. So I would have the mirror in front of the patient. Okay, but before we do it, right, I would have a line thrown in the middle of the mirror. Okay, you may have X's here and also here. Okay, and you always telling your patient you should be on the O side, on the X's side. Okay, so the idea is for them to cross the midline. I may be sitting in front of the patient, okay, and use my arm as a vertical reference for the patient. Okay, if you passively correct the patient, they would resist. They are very stubborn. Passive correction. And when they see things vertical, they follow. Okay? You may tell your patient, okay, look at the window. Do you see the frame of the door or the frame of the window? Okay, you look on something that is vertical in your environment and you tell them, just follow. This is the vertical, not here. Because that's their perception. Okay, that's they are vertical. Okay, so you tell them what is vertical, you follow that. Okay, so interventions to be done in sitting. We could do stabilization, interventions, stabilization reversal, approximation. You can do rhythmic stabilization. You can do alternative isometrics. All these could be done. For the control the mobility, you do weight shift, you do dynamic reversals, okay? You do left and reach, okay? So everything could be done in sitting. Special attention to the patients with Pusher syndrome. You add something vertical to their environment, okay? That is the magic thing about the Pusher syndrome. Receiving something vertical and they fall. Okay? Questions about the sitting interventions? Anything missed in this table?
When you had them like this, what was this for? Like, is this like?
It's just for people with subluxated shoulder, just protection for shoulder, etc. In your IFO book, it says also for patient with cognizant problems. Any questions? Okay, let's practice the interventions in setting.